I am one of those people who does not like to read bios, but I'm going to make an exception for this panel. As our panel gets settled in, I'm going to read you their bios because I think it's pretty extraordinary, the mix of views that we have here and the array of knowledge. So on this panel, we have Dr. Stephen Lane, who I think is known to everyone here, but just in case, he was a clinical informaticist at Sutter Health and in charge of privacy and interoperability for a number of years, and then moved to Health Gorilla, where he is the chief medical officer. And he is, of course, a board member of the Sequoia Project. He is chair of the Care Quality Steering Committee. For those who follow federal health IT policy, he is a member of the HITAC, which is an advisory committee to ONC, and has other leadership roles. But most importantly, he's a practicing physician. So having that clinical view on how do we use information to care for patients while still protecting privacy is a really important point of view. So another point of view that we have is really the technologist point of view. Mohammad Jafari is here with us as an independent subject matter expert on security, privacy, interoperability, and consent. Mohammad has also been instrumental in standards development at HL7 and other standards bodies. And one of the key things that's important for this conversation is that he was a co-author of the FHIR Data Segmentation for Privacy Implementation Guide and was a principal investigator for ONC's LEAP project on FHIR consent APIs. So those technology approaches that help us solve that clinical problem of how do I share data within the bounds of the privacy and consent rules that I live under is really important. And then finally, we have Nichole Sweeney, who's General Counsel and Chief Privacy Officer at CRISP, which is the state-designated HIE for the state of Maryland. The state of Maryland has come up a couple of times during this meeting because they are presenting a unique privacy rule for data information sharing that I believe is already live, but Nichole will talk about that. It might be December the 1st. She previously worked at MITRE and was providing strategic guidance to federal agencies, including ONC and CMS, on their interoperability initiatives. So we have the clinical, we have the technical, and we have the legal. And you really have to bring all of that, plus, frankly, the patient and the regulator together to think about how can we share information for care and still comply with privacy and consent requirements. And that is the topic for this group and is also, of course, the subject matter for a new work group that we're standing up, the Privacy and Consent Work Group. I am not actually seeing the clicker to advance slides. Nichole has it. Thank you, Nichole. So what I'm going to do is just give a couple of slides about the work group. And this was not actually the final slide deck, but that's okay. We'll go back a slide. Let me just talk about the work group. The work group is just being formed now. We have two co-chairs, including Dr. Lane and Devin McGraw. Devin sends her regrets. She couldn't make it out to San Diego for this meeting, but those of you who know Devin, she has served at OCR and has been a privacy advocate for decades and is really interested in really that practical implementation view, which is the unique Sequoia approach, right? We're not going to actively advocate to change privacy laws. What we're really thinking about is what are the ways in which we can do things to both share and protect data. And so that's really the focus of the work group. And we've had tremendous interest in being part of this work group. We're very excited about that. And if you have interest and have yet to express your interest, just flag Sequoia staff member, and we'll have a conversation about that. So one other thing that I want to say about the work group is that we want to build on the good work of others, and that's part of why we want to have the HL7 data segmentation for privacy talked about here, because again, being radically practical is part of what we want to do and work with and build from the work of others and not sort of recreate the wheel. So with that, I'm going to start with a question for Dr. Lane, because he is our co-chair. So why is now the right time to be focusing on implementation of tools to address privacy and consent? Why now?
Well, that's a great question. And I think a great place to start our discussion as well. Obviously, privacy of patient information has been important for years, right? We have been living with HIPAA and privacy rules even before then for quite a long time. And as we have advanced in our creation of health data, our use of health data, and our exchange of health data, the need to keep that data private has just become greater and greater. Deputy Secretary Palm said to us earlier today that there's this balance that needs to be struck between data sharing and data privacy. And I think a lot of the changes that have occurred over time and recently in particular have really highlighted the need for this focus. So, I mean, we started the journey of interoperability probably 15 to 20 years ago now, and it was kind of a slow start, and then there have been a lot of improvements along the way, thanks to the work of many of the people in this room. And as we have shared data more and more, we've realized that it's not all good, that there are unintended consequences to having access to data, to being able to exchange data. So the more access there is, because we've solved technical challenges, connectivity challenges, the information blocking prohibitions have really further increased the access to data. That has just increased the concerns that we see on the part of providers and of individuals. I mean, individuals who now have access to view their records, through open notes, et cetera, they see what's there, and they go, whoa, I hadn't thought about this. I didn't realize all this information was available. How do I feel about that? So I think we have an increase in patient concern. And then, of course, there have been significant changes in the legal landscape, both at the federal and the state level, as you mentioned. I mean, with the Dobbs decision and the change in federal rules around female reproductive health in particular, I think that's just highlighted the fact that there is information out there that can have, again, unintended consequences, information that can be weaponized, that can be used to the detriment of individuals and providers as well. So I think that's been a concern. And then as that happens, of course, the states have continued in their process of trying to make things better, within their realms. So you've got states creating additional restrictions. So the landscape has gotten very complicated. And we've, especially I think in the last few years, I mean, Devin and I, since the Dobbs decision, have just been, and all of us, have been thrown into all these conversations. And there's a lot of interest and a lot of talk, but really not much has been done. And as you've heard, there's been tremendous work done technically at HL7 to actually lay the groundwork for our technical ability to be able to protect privacy in ways that we really haven't historically. So we've got need, we've got tools, and this is a great time to finally convene the stakeholders and say, okay, what are we actually going to do? So I think the work group is a great way to move this discussion forward. We have reached out to the folks at OCR. We're reaching out to the folks at ONC. We're hoping to get them to the table, because when you have these discussions, you always come up against, well, HIPAA's not perfect, it's old, it hasn't been retooled for the modern era. So, we really need OCR at the table, and we need ONC there because we've got changing rules coming. We've got HTI-1 coming, which has a very particular focus on how shall we technically support patient restrictions under HIPAA? So we anticipate when HTI-1 drops any day now, that we're going to see what's going to be required for certified health IT to help us with these HIPAA restrictions, which have always been fairly vague. You know, it's all the HIPAA rule implementation has really been built on a paper model, and we need to rebuild that on a digital model, and I think this is going to be a great opportunity. So the time is really ripe for this work. I think we've got a great group that's coming together, and I'm thrilled to be able to co-lead that with Devin and with the participation of the tremendous folks, many of whom, again, are in the room, who volunteered to participate.
That's fantastic. And a little later, maybe I'll ask the group why Sequoia, but we'll leave that for the end. Nichole, really this question, right, of state level policy and maybe even jurisdiction level policy within a state is really a big part of the privacy conversation. And obviously CRISP works in a number of states. So tell us, what does it look like and how are you addressing that?
Well, it's fantastic job security, first of all. So there's a lot to be done. But before I talk about that, I was given permission to nerd out a little bit with this slide, because I think it's helpful to have a context where we say, this is why you feel sort of in the middle of something, or you feel a paradigm shift. And just real quickly, not healthcare related, but to give an analogy, my son came up for the bus a couple days ago, and I said, how's your day? And he's like, oh, it's just terrible. He's 10 years old. What is going on? You know, he has a lot of terrible days, to be frank. But, and he said, I got my class pictures back, and he pulls out, and he said, I was supposed to get 12 wallets. And he pulls out a sheet of 12 wallet-sized pictures. He thought he was getting 12 wallets with his face on them. So a very easy mistake to make, especially when you're 10. But I think just like that, some of this conversation is, are we talking about wallets or are we talking about wallets? And which one you're talking about really orients you to the conversation. And I think sometimes before we even have the conversation, we need to say, are you talking about wallets or are you talking about wallets, right? Where are we on this paradigm that you're talking about? So I find it really helpful to mark this out for myself. So this is the slide that you all are looking at. In a very short period of time, although it's depressing, at least to me, how far away 1996 is, we went from just a complete shift, really, from a legal perspective, where we basically lawyers, everywhere were saying, hey, you can share this data, but HIPAA says it's can, it's not must. So it's just better for everybody if we don't share it, right? From a legal perspective, it's gonna get us into less trouble if we don't share it. And I think we're all familiar with the consequences of that and why in 2021, a little earlier than that, around 2020, we had the Cures Act and information blocking, which says, hey, if you can share the data, you really need to share it unless you have these exceptions. So we are going through a paradigm shift, as Stephen talked about, and it is hard. And if you feel like you are experiencing whiplash, it's because you are. And I think when we're having the conversation, are you talking about HIPAA wallets or are you talking about information wallets? And where are you on that paradigm, and what are you talking about, and what's your level of comfortability when we have these conversations? And Dobbs brought that into really stark contrast when we were thinking about the federal landscape versus the state landscape. And so as the General Counsel and Chief Privacy Officer of CRISP Maryland, CRISP DC, and CRISP Shared Services. Isn't it great working for a not-for-profit? We've got 17 titles. I get to see that very up close in Maryland and DC, but also among our other affiliate HIEs that CRISP Shared Services represents, including states where certain reproductive procedures are extremely limited or not available and or criminalized. So trying to navigate that tension between HIPAA and information blocking and having state level privacy in a world where we want to be sharing data. It is a good thing to be sharing data. But my fear is that if we ignore the state level privacy concerns and the local privacy concerns, and if someone is saying to us wallets and we hear wallets, that we're going to be in a situation where we are not able to share data in the way that we want to share data because we are not thinking about those very local concerns. So I feel lucky to be a part of an organization that thinks about those local concerns, and as an HIE working in a state or regional area, privacy is local. What matters to people is local. And so being able to say, okay, where are we on this spectrum? What matters to you from a state level, and how do we make sure that patients understand what part of the spectrum that we're talking about and when they want to be on one side of it versus when they want to be on the other?
That's great. And can you just factually tell folks what the Maryland state law is? They may not know.
Yes, I could probably do a whole speech about this. Actually, I have. So last year, this past legislative session, Maryland enacted, which is HB 812, if you've heard people talk about it, which requires HIEs to block or segment certain reproductive data before it is shared outside of the state. In the state of Maryland, EHRs are considered HIEs, so any of the major EHR companies, this also applies to. So we've had about 9 months of trying to figure out how do we do this, and how do you do it without blocking the whole record, and perhaps most importantly, how do you do it in a way that patients understand what is happening, and you aren't overly inclusive or under-inclusive. So that law goes into effect December 1. It is a code-based law, so it is not going to capture notes, and it's not going to just stop a record if there's any reproductive data. It's specific codes. The next question might be, what are the codes? And the answer is, we don't know yet. So December 1 is quite soon. So we'll see if it goes into effect December 1, but that is the law in Maryland. So if we take that and kind of put the TEFCA and the national network and the privacy side on it, that means to be able to do national data sharing in Maryland, you have to first be able to identify and hopefully segment records and reconstitute them so that we don't end up with large swaths of the population having records totally blocked. But in the absence of being able to do that, blocking those records with that information before they leave the state of Maryland.
That's great. Yeah, so that's a pretty dramatic example of what we're trying to solve for, right? Mm-hmm. Nobody wants the whole record to be blocked. So Mohammad, having automation tools to help solve for some of these issues would be really great. Do you want to share a little bit about the tools that exist today and where we are in terms of developing tools, and then how FHIR might change the landscape?
Of course. And thank you. So I think on a broader note, I just wanted to say that, we could maybe say that we have the wires and the electricity and the outlets, but that's the building blocks and the infrastructure that's in place, but we still need to bring appliances in and plug them in. It's still, there's work to be done at a higher level in order to fit the use cases that are actually pragmatically out there that need either data segmentation or a patient consent to be more specific. But I wanted to have a quick overview of what we have now, which is we have the consent resource. The consent resource provides the data structure and the data object to capture patients' preferences. This is both interoperable in a way that is standardized, as well as granular. It will allow capturing granular rules and granular preferences by the patient or their proxies. And also, hopefully, even a more mature level, computable consents, where we can have the rules recorded in a way that are machine readable and are able to scale and enforced without manual intervention, basically. So we have the consent data object, we have the FHIR API. The FHIR API is kind of like the outlet. It allows us to do the basic operations of creating a new object, updating that, deleting it, and so on and so forth. So that infrastructure is there. The consent resource itself allows granular rules to be recorded. The granular rules, in part, some of these have been implemented before, things that are related to the data that is subject to the rule or purpose of use. These are sort of more higher level rules that are already implemented in some systems. But there's more to that. It does support recording rules that would cover specific clinical code even, or categories of sensitive data. And that's where the data segmentation conversation kind of dovetails with the enforcement of consent. Basically, having the data tagged would enable us to use the consent resource to give the patient the power to say, I do want to share this type of data, this broad category of sensitive data like substance use disorder or reproductive health, or I do not want to. And so these are the hooks basically that allows articulating rules in a very granular level, including broad rules that would apply to a broad category of sensitive data. So basically we have the building blocks to articulate these rules, and we have the building blocks to record them in the form of a standardized object that is also subject to a standardized API. So we know how to retrieve the consent, how to create the consent, and how to apply it. And I do want to also make this point because it's often maybe misconstrued. We don't have to be operating by FHIR in order to enforce FHIR consent. So a FHIR consent can capture the rules and capture the parameters of the patient preferences, but it can be applied at the point of enforcement in all kinds of other technologies. It could be a proprietary database. It could be other forms of exchange and other forms of standard data objects. So the FHIR consent is where the rules are recorded, and where the rules are applied and enforced could be non-FHIR still. And then what we don't have is more sophisticated profiles that are kind of tailoring the FHIR consent resource and the operations, the other operations that are related to the consent management in a way that is more tangible and more crafted for the specific use case. So these are usually covered under profiles in HL7 FHIR. A profile basically is sort of like a narrowing down of the use of a set of resources for specific use cases. So we kind of clarify how to use the resources to record data, how to use the resources to what kind of attributes, what kind of value sets are required to be supported in order for a specific implementation that is tailored to a specific use case. So there is I wanted to mention the IHE privacy consent and FHIR, the PCF profile, that sort of lays the groundwork for having using FHIR consent for privacy, especially as exchange use cases. So that's a great start, but we do need further profiling and implementation guides for more specific use cases, including consent management operations that are sort of covered in this slide. So this is a broad inventory of all the things that a consent management system needs to do, from requesting to capture consent to the actual capturing of the consent and allowing a patient or a proxy or a user to navigate through the form, to understand the content of the form, to make an informed decision, and then ultimately to record that in the standard format, and then being able to retrieve that, export it for human readable use cases, such as like a printout for someone's record, and then allowing the patient to revoke that, and then allowing patient to have access to the audit record of what that consent actually authorized. So where the data ended up being and authorized by what parts of which consent and what parts of the consent rules, in order to have that feedback loop for the patient to revise what they have decided in case they want to change their mind. And then all of this can also and should also be enabled programmatically, so that there's an opportunity for integration so that not every organization has to implement an entire ecosystem of consent management. We can outsource it to external organization and then build a workflow integration into an external consent management provider. So that's where I want to stop. So we do need to cover more implementation guides, provide more implementation guidance for some of the specifics of these use cases. I put a slide here to get a specific example of what a profile would basically lay out, like a more advanced profile, is the use of questionnaire, FHIR questionnaire, in order to basically map a paper consent form into a consent management ecosystem. So FHIR questionnaire and FHIR questionnaire response is a pair of resources basically that allow a very generic way of capturing structured data. So you would take any sort of form or questionnaire, and that there's a one-to-one mapping between the fields in that paper questionnaire basically and the data that's being recorded in the form of a consent, a FHIR questionnaire and questionnaire response. So that questionnaire can be served using a interface, a user interface to a patient, and then the results captured in the form of a questionnaire response. And then there's facilities, there's implementation guidance in some of the existing profiles to record the information, how to extract the response, the raw response from that questionnaire, and turn it into a computable consent object. So all of these building blocks are there right now. But how to use the consent, how to use the FHIR questionnaire, how to extract the consent, how to define those operations, the details of these things still needs to be crafted further, and there needs to be further implementation guidance and examples on how to do these things. So maybe I pause.
That's great.
There.
Yeah,
Thank
that's a great overview, and I'm just curious, have there been sort of pilots and places where you've worked through some of the implementations?
There's definitely been pilots. There's the LEAP project that was funded by the ONC was basically an implementation of a consent engine, a consent decision service, where basically we would have the consents captured in that format, in a computable format, and then we would have an authorization engine that was capable of responding to queries live, in the course of a workflow. Am I allowed to do this right now? And then it would match the context of the workflow with the rules that were crafted in the consent, find the applicable consents, find the applicable rules, and then give a yes or no decision whether you can proceed or not, or if there is obligations that would apply, should you choose to proceed. So there is that implementation, and there has been other implementations, the FHIR resource, FHIR consent resource as well. And I'm aware of some vendors also who have worked on providing FHIR consent management tools or more generic questionnaire management tools. But at a larger scale, I think that's still work in progress,
right.
to get something in place that is under like heavy load at the kind of a pragmatic level in privacy use cases, for sure.
Yeah. In the last panel where we were talking about usability, it took me back to sort of conversations, what does usability mean? And I always like the definition. Usability means that you make the right thing to do the easy thing to do, right? And I sort of feel like that's a good guidepost for the work of the privacy and consent work group. We're trying to find the way to make the right thing to do the easy thing to do. So, Stephen, I think we're excited about these tools, and we're also excited about TEFCA. So how is Health Gorilla thinking about these challenges with privacy consent as you move into the brave new world of TEFCA?
As you say, Mohammad, these tools have been built out. I mean, when you go through this, I've been listening to you give this talk for a couple of years now, and every time I understand it a little better and a little bit deeper, and I go, wow, it's great that there was this LEAP demonstration project. But as you say, we haven't actually built this into real-world consent management. And with TEFCA, of course, we anticipate that we're going to be seeing an increase in exchange, an increase in sharing of data, between participants, sub-participants, across the QHIN network. And this is a great time to build this into the fabric of exchange for this country. So Health Gorilla, as a candidate QHIN, has really committed itself to this work, to building a truly privacy-respecting QHIN. And it's obviously not going to be done overnight, but we're working with Mohammad, trying to see what are the pieces of this that really can be built in the real world. And I think, again, one of the key things I'd like to see our work group work on in the coming year is just that. What are the most practical things, given all these tools that we have, this armamentarium of tech, what are the most practical things we can do to address the real problems that we have today? So I mentioned HTI-1 and the coming standards around HIPAA restrictions for patients. So I think that's something that we absolutely want to work on. And we've talked repeatedly about DOBS and female reproductive health data, but we also know that there are state laws that touch on other kinds of reproductive health data beyond abortion, STIs, contraception, et cetera. I mean, the number of state laws is really increasing. So as a QHIN, we are going to need to manage data exchange across the country. We're going to need to, as we start to build these rules, consider how they are going to apply if a request is coming from California for data in Maryland or vice versa. So it really starts with figuring out what is the data you're going to protect. I mean, you mentioned the Maryland law, as being a code-based law. And that's where a lot of this starts. We can't boil the ocean. We know we can't necessarily find all the data that's lost in the text of a note. But starting with code sets, starting with value sets that represent the data that is highly sensitive, be it reproductive health data, be it substance use disorder data, et cetera. So we're really focusing first on identifying those value sets. Well, the good news is that SAMHSA has already done a tremendous amount of work on value sets for substance use disorder and the data that would be covered by Part 2. So we're planning on using that. Reproductive health, clearly, pretty much anybody you talk to is the other super high priority use case. And lo and behold, AHIMA and Health Gorilla are working together to develop the value sets for you, for all of our ability to be able to protect female reproductive health data and all of the other reproductive health issues that flow from that. So that work we are hoping will be done soon, before the end of the year is kind of what we're targeting. And AHIMA is going to be helping to make those value sets available to the industry, with the input of the folks from our team. And then there's a whole host of other privacy use cases, whether you're talking about SDOH data. I come from California. We've got this data exchange framework, which is all, partly about including the exchange of social data with folks who are not necessarily HIPAA-covered entities. So we need to be able to identify that data. Gender-affirming care, another area where, highly sensitive. And there's a list of maybe a dozen of these privacy use cases. And then there's all the issues about contractual and data use agreement restrictions, right? How are we going to protect data where a patient has made this data available with certain expectations, but that they may want to consent to make data available for research or for reuse or for other purposes. So there are a lot of use cases, and I think, again, most people will agree that substance use disorder and abortion care are the places to start because there are very clear laws there. And then I think we need to prioritize that list. And then, when it comes to consent, here again, some of this data clearly requires a consent. There's a standard consent for Part 2 data, and yet some states have written additional laws that impact substance use disorder data. So whenever you start talking about this, it's easy to just get overwhelmed. It's easy to say, this sounds too hard. And that's what we've been saying for the past 5 years or so, is like, yeah, this is really complicated. Someone should work on that. And I think now is the time to work on it. And as you say, TEFCA is the time to work on it. You know, we're going to have this period of time where TEFCA exchange is going to begin, hopefully next month. It's going to ramp up over the coming year. We're going to be seeing these additional use cases coming online. And it's a great time to have Sequoia, that's so close to the TEFCA development work as the RCE, also supporting this kind of work, and then to have the QHINs at the table participating in that, and the HIEs as well, because of course the HIEs almost have the luxury of being in one region where they're dealing with 1 or 2 or 5 states. And the QHINs have to deal with all the states and the territories, et cetera. So there's a lot of work to be done.
Can I add something to that? Sorry.
Of course, please.
I think I'm so grateful for what you said about, you know, like we've been talking about this for 5 years. It's having a conversation with a group of people who maybe coordinate things recently. And my message to them was, do literally anything. Like I think we are getting, and that's unfair, there are lots of people doing stuff, but what I see right now is we're getting caught up in, not this work group, which I'm very grateful for, but what I've seen is that we've been caught up in the tens of thousands of reasons this isn't going to work. And oh my goodness, if we start with codes, then patients won't know about their notes, and then there's going to be this expectation. Like it's never going to be perfect. I feel very similar about this that I do when someone comes and asks us for data to run an SDOH study to figure out how to do blah, blah, blah. I'm like, well, you could spend 6 months doing that, or you could just make housing or food insecurity better and childcare better, and that would probably help too. So anyway, that was a joke. Didn't land. It's okay. Sometimes that happens. But you know, we don't want to make. We don't even want to come close to making the perfect the enemy of the good. Like we are going to try, we are going to fail. Some of us are going to end up in newspapers. It's not going to look that good, and we still have to do it. Because I will tell you, the consequence of us not doing it is that states like mine, and the one that we're sitting in, are saying, we are not seeing the type of leadership we need on this, so we are making our own laws, and those laws are not great, friends. You know, they are not implementable from a technology perspective, or they are, but it's difficult, and it's even more confusing to patients. So I think, you know, my message is do literally anything, or have people tell you what you have to do. This is my classic, like, either you're at the table or you're on the menu. And I think we're very close to being on the menu in a way that's going to drive interoperability back a very, very long period of time, unless we step up and start doing literally anything.
Well, with that, let's open it up for questions from the audience, or impassioned pleas from the audience. We'll take both.
Hey, I'm over here on your left, I guess. It's Bill Howard. Nichole, that was great. In the spirit of kind of doing anything, I guess what I was wondering, I'm seeing a lot here related to trying to control it on the input side. And what I'm wondering, in the spirit of trying a couple different things, if it's also possible to control it or do something on the output side. And what I mean by that is, if you think about like the way banking works and the way you can sort of lock down accounts, or you can get notified of a charge or whatever it may be, could there be something, and I've seen this implemented in a couple of the HIEs and other places where they've sort of alerted when your records are accessed. And I wonder if that type of a solution, combined with what you have here, you know, kind of go at it from multiple angles, because I really think trying to implement this is really hard, because no one's going to probably agree on that set of codes. And what I've seen when you implement this is you end up doing harm, you end up cutting out too much data. And I just wonder if there's another way to also look at it on the read side, not just on the write side. So thank you. It's great you got this project going. I think it's awesome. Thank you.
I don't mind taking a first stab at that. I actually think, Bill, that that we're primarily or initially focusing on the output, that is to say the queries for data. Because I think that that's the time you can do the assessment. You know, when somebody's going and requesting data, that's when you can say, gee, is this data that requires a consent? You know, is this data that you're allowed to release, you know, based on laws or based on data use agreements, et cetera. So I think the key is really figuring out which data and then in what circumstances you might want to block that. You know, they use the word segmentation, which never makes sense to me because I think of walls and segments and like different databases. It's really, in my mind, it's about data tagging. It's about saying, what data is this? And then managing that data, releasing that data only according to the rules that are applying.
And I think you could see a world too where the output potentially is, like, this is my dream, right? Is like a patient sitting down with a tablet with their clinician and saying this, yes, 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 no, 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 no.
No, not with the clinician.
No.
We don't have time to do that. The patient has to, you got to design an app where they can do that on their own.
Yes,
I don't sit down with my banker and say yes, 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 no, 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 right? I just fill out the form.
But in any event, yeah, something very, very good point. But something that where again, this is like crawl, walk, run, and we've been adding fly recently too. So and the codes are absolutely first, but then being able to say that this is really, privacy is about you, right? Are you talking about wallets or are you talking about wallets? And let's like block the wallets and not block the other wallets. So I think it would be great to get to that point where we're talking about output with patients.
Also, Bill, I love your point about, you know, wouldn't it be nice if there were alerting mechanisms? You know, our bank can do that. So many apps can do that. I think eventually that would be great to see that. There was a question over here.
And there are very bright lights, so I can't quite tell
We've got
that
one?
we theoretically have 4 minutes left, but I'm being told we don't.
We're getting a very clear no.
The monitor up here says 4 minutes and 18 seconds. But if there's other questions, we can maybe entertain one more.
Yeah, sure. I saw you waving.
Sure. Thanks. My name is Helen. I'm actually a healthcare regulatory attorney. I'd be interested to get your perspective on those situations that you're not able to capture consent. First of all, I think this is a critical piece of the puzzle. I think it's amazing. I think that's going to take things leaps and bounds forward. I've been working with HIEs for over a decade. My question to you, and I'd be interested to get your input, is for those cases, because consent management and collection is a very tedious process. It's why a lot of HIEs went to an opt-out model. I come from a heavily regulated state, New York, New Jersey. We got tripped up over genetic, HIV, AIDS, mental health, behavioral, because not only do they regulate the consent, they regulate the form of consent, and the exceptions to that are very narrow. So once we were able to get back past treatment use cases, but when we started going into healthcare operations, pop health, things that started to traverse outside of treatment. Now you had two choices if I didn't have the appropriate consent. Either I block everything or I take a risk. So I worked on a pilot about 10 years ago where there was an application that actually sat on top of the EMR and it actually tagged data. So it's not actually an end user thing, but it's a systemic thing that actually tags data based on algorithms that you set up based on the law in your state and then controls the output. Very easy if it's data segmented, if there's discrete data fields, very easy to find. But it also captures things in things like PDF and whatnot. So if it can't be segmented out, HIV/AIDS to the PDF, it would just block the whole entire thing. Moreover, it would allow clinicians to break classes in order to get that for treatment, but let that not go out for pop health or other kinds of non-treatment diseases. What are your thoughts on that model as a complement to what you're doing? Is there room for that? Is that something you see as part of the overall structure going forward with Sequoia and TEFCA and all that?
Do you want to comment on that?
I kind of want to say that, you know, it's inherent part of that process. These are not alternatives. These are, you know, inherently related and connected. I think doing that level of, that form of automated data tagging, even though it's not perfect, you know, there's definitely going to be problems with inference. There's going to be false positives and false negatives. But the gravity of the risks that ensue from not doing that is always a good measure to see whether it's justified to do this work or not. And as Nichole mentioned, you know, we need to start from somewhere. So having an automated data tagging engine or a product is a necessary part, because it's, we can say the patient has the right to consent, but it's extremely onerous for the patient to have to go through, like comb through their record and identify, does this, fall under this category of sensitive data? Do I want to, restrict line item by line item, right? It gives, part of the segmentation is that it gives a rich language, a high-level human readable language for the patient without having like a deep clinical knowledge to be able to make decisions, on a large sets of data without having to go through the content of that group, right? And that requires a data tagging solution that would provide that to close that semantic gap between what the patient understands at a high level expectation of privacy versus what that translates into from a low level clinical and technical perspective.
And I think that's exactly where health data utilities come in. Having a health data utility at each state that understands what needs to go on top, what are the things that need to be tagged. That's what we're doing at CRIS Shared Services and CRIS with this reproductive law, and really working, this is getting very aggressive, really working together with the QHIN model and the health data utility model to bridge those two things.
Please join the work
As
group.
you can hear, this conversation will be continuing as part of the work group, and I want to thank our panelists, but before we do that, can you just click to the next slide for me? Because we want to give a little bit, keep going, a little bit of direction to folks on what will happen next, but I'll let Alan do that. But let's thank our panelists and all engage in this work moving forward.